I would like to introduce Dr. Mike Misel to the team. Dr. Misel is our professor of pharmacy at both UCSD SCAC School of Medicine and UC San Francisco. Dr. Mike Misel is our primary inpatient transplant pharmacist for our abdominal transplant program. For those of you who may not know, we have 3 transplant pharmacists working with our transplant program, as well as a contingency of transplant residents that are primarily, they round with our teams here in-house, but they're also primarily present in clinics. I'm sure Dr. Misel has some fairly informative presentation here for us on transplant pharmacology, so the floor is yours. Thank you.
Well, I'd like to, my name is Dr. Misel. I'm the pharmacist on the abdominal transplant team and Med Team 7, which helps take care of our pre-liver transplant patients. And so I'm going to talk to you a little bit about both groups today. I'd like to thank the Transplant Council for inviting me to speak today. It's an honor to be here with you. And I really want to thank all of you for being here today on a day off to come in and be here and show the initiative to want to learn more. And like Alexander Ossie had mentioned, I think that shows like your commitment to our program, and it's an honor to be here with you today. So what I would like to do is kind of talk about what my goal is here today. And basically I want to give you guys some information, review the fundamentals on caring for patients, transplant patients, so I'm talking about kidney, liver transplant patients, and I also want to talk about care of some of our end-stage liver disease patients, because I know some of you may have some particular questions about those groups. Just out of curiosity, how many of you, is this your first time coming to one of our transplant conferences? All right, that's a large number of you today. So we're going to cover some good information I think will hopefully help you out in your daily activities when you take care of these patients. So traditionally, we think about transplant is in this early perioperative phase. Here at UCSD, it tends to be within the first 3 months after transplant. Any patient comes in for a transplant or is readmitted to the hospital generally falls on to our transplant service. And so that's where a lot of my talk will be spent, on how to manage those patients. However, in the last year, we've had the UCSD Center for Transplantation, or CHAT. We have the Center for Hepatobiliary Disease and Abdominal Transplant, and that includes Medicine Team 7. And that covers a larger group of patients, because we have to think about a transplant patient as not only did they get a transplant patient, but a transplant patient can also be considered somebody who's waiting for a liver transplant. And our job is to, before the transplant, obviously address all of their challenging issues that they can have, keep them alive, and maintain their quality of life as long as we can, till the time they can get a transplant, and then some. So I'm going to talk about some of those challenges that we have in doing that today as well. So let's start off with immunosuppression. Here at UCSD, Alexander Ossie went over the programs that we have, and pretty much all the transplants that are done out there in the world, we're doing all of them except for the small bowel transplants. I think there are some programs now that are starting to do different like hand transplants and stuff like that from people who had traumatic injuries, but that's still relatively new. So with immunosuppression, why do we do it? Well, obviously it helps, basically the patient's born with an organ that their body knows isn't theirs, and so we have to give them medication to help calm their immune system down. Hey, just, don't attack this organ. I know you recognize it as something different, but, don't destroy it. So we have to give them some medication that's lifelong to help do that. We have protocols in place. I think those are posted online somewhere. You guys have seen them. But remember, immunosuppression is also individualized for that patient. Everybody comes in with different risk factors for rejection or infection or cancer or some other complications. So we always have to find this balance to make that happen. We want to obviously prevent side effects that can come along with these too. So as you can imagine, we're really dealing with a tricky balancing act here. We're trying to give them enough medication so their immune system doesn't attack the organ, but at the same time, if we do too much, we're going to give them adverse effects from the medications, and we're going to increase their risk for cancers down the road and increase their risk for infections. Now, it sounds like an impossible task, but actually, with years of experience and staying up on the evidence, we can actually maintain a very good balance there. But it takes all of us working together to help make that happen. We have to understand where the pitfalls are, where the challenges, the little mines in the minefield are that we can avoid to help make all this happen, and it requires all of us to help do that. We have lots of immunosuppressants out there. They come in different categories. Here's just a little list of them here. And our traditional regimens across the board here at UCSD, depending on, regardless of the organ, is basically consists of the following. We have a calcineurin inhibitor that's either tacrolimus or cyclosporin. We have them on a steroid. And then typically we have them on mycophenolate, but occasionally they might be on azathioprine too. If you guys worked at different transplant centers, you might see they do things just a little bit differently. And that's because the literature, when they do studies, tends to be smaller groups. And so there's a little bit different ways of doing things. There isn't any one program that does things right, otherwise everybody would be doing it that way. So we're doing things right when you look at our outcomes. Our patients are doing well, so we can be confident in the things that we've done. So this is a map. It just kind of tells you where the different drugs work on the immune system to help prevent infection. So we have a few different things, and basically the gist of this is it shows you that each of these medications that we give to our patient works at a different step in the immune system pathway, if you will. And so together, we can use lower doses of the medications, which helps us reduce the side effects of the medicines. And it also helps us increase the efficacy of the medications. So let's talk about calcineurin inhibitors. You guys know that primarily as tacrolimus or Prograf. It's kind of the backbone of our immunosuppression regimen, because when this class of medications came along, they really ushered in the success that we have in transplant today. Before we had calcineurin inhibitors, we had like azathioprine and we had some steroids, and together, they did a little bit, but they, had to use high doses, so people had side effects, and they still weren't as good as the things we have today, so outcomes were much less. Tacrolimus comes as IV capsules or suspension. We give it twice a day in the hospital, and we have standardized times regardless of what unit you're in to set them at 7 a.m. and 8 p.m. And we want to do that because we're trying to give this medication on an empty stomach, which helps improve absorption and keep levels consistent. Here's an example of how levels can vary if we weren't doing it on an empty stomach. We have a graph here that kind of shows you that the levels can show up at different time points depending on absorption. And so we try to keep this is kind of the preferred one, this black solid line. That would be kind of the thing that we want to show a nice peak, good absorption, and that translates to a better area under the curve, which means a better immunosuppression. And when we get the level, it means it helps us determine where we're at with that balance we're trying to maintain. We have different target levels, and I'm going to talk a little bit about liver transplant a little bit later, but you can see that the levels vary. Like if you were to look at all of our protocols, you'd find that the levels vary according to the type of organ that was transplanted and how far out they are from the transplant. We always hit patients kind of harder up front in the immune system, like when they get the transplant, because we're trying to get the body and the organ kind of acquainted. We're kind of like two strangers, if you will, providing punch at a party to facilitate, a good relationship. So, and then there's a little bit of a tolerance that comes along with that. And so that's why the levels come down a little bit with time. The kidney patients, they have a little bit different levels, and they kind of fall into three groups. Group one would say it'd be a high-risk patient where we need to use additional immunosuppression to help prevent rejection. Group two would be maybe a living donor, or a donor from a living recipient, and we've used maybe thymo for 3 days, and so we need to use a little bit higher tacrolimus levels to help maintain appropriate immunosuppression. And group three would say be a kidney from a deceased donor who got a full course of thymo, and so they don't need and they don't have any other risk factors. Then they don't need as much immunosuppression because a full course of thymo is doing the work for the first 3 months after transplant or so. So then we don't need as much tacrolimus or Prograf to do that. Tacrolimus is available IV also. We don't usually use this. We only pull this one out if we have a patient with a small bowel obstruction, they're strict NPO, they're in the ICU, and we need to get the levels up or replace something the patient was taking. The other time we see this is when you have a liver transplant patient, for example, who's in the ICU, and we've been giving them oral tacrolimus for a few days, but we're really not making progress on their level. The gut's just not working, maybe from the anesthesia, the pain medicines, they're just not absorbing it for whatever reason. So we want to get, by post-op day 5, we want to make sure the levels are close to target, because otherwise we're going to run the risk of rejection. So if we're getting that situation, then we're going to give them some IV for the time being, in addition to the oral. And then once we get the levels and they start absorbing, then we can stop the IV. Now, something really important that I've said before, but I think it's always worth saying, is that this requires a dedicated IV line, okay? And so I want you guys to label these lines that are infusing the tacrolimus or the cyclosporin, because the drug adheres to the tubing. And no matter how much you flush it, there's always going to be drug in that line. And so if we draw levels off those lines, they're going to be contaminated, and the levels are going to mean nothing to us. And we can't check it again that day. You only run them once a day. So then we're kind of flying blind for a day, and we don't know where we're at with that balance. And so it's really important to help make sure those lines are drawn and labeled, and we're drawing the levels at the right times. Cyclosporin is another calcineurin inhibitor that we have. It's also kind of given twice a day, and it's also given on empty stomach the same way we do the Prograf. It also is susceptible to the food interactions that we talked about, so we want to give this on an empty stomach. And this is also available IV. Now, the tacrolimus IV that I had mentioned just previously is given as a continuous infusion over 24 hours. All right, so dedicated line, you need to have that line freed up all day for that tacrolimus. With the cyclosporin, the difference with this one is this is given twice a day as an IV piggyback, generally over 4 to 6 hours each dose. All right, and again, label the line not to draw cyclosporin levels off of this one, because the same problem will occur as it does with the tacrolimus. Now, how do we decide which calcineurin inhibitor we're going to use, cyclosporin or tacrolimus? Well, it depends basically on their adverse effect profile. We know from experience that cyclosporin tends to be a little more toxic for the kidneys. So that's generally why, it may be slightly more effective overall if you look at rejection rates than cyclosporin. So that's why we favor tacrolimus. But they still have their share of goods and bad things. Neurotoxicity is a little more common with tacrolimus. Neurotoxicity comes in the form of tremors, headaches, like some kind of neuropathic pain, as well as high as like seizures. It can happen. Hypertension is a common thing too, and so we obviously have to monitor this post-transplant and keep those things under control. Now, some of you take care of our patients like right after a transplant, and just to let you know, the team will tolerate a little bit higher blood pressures during that time because they want to make sure the organ is perfusing. So sometimes if the pressure is like 140s to low 150s, they may not want to jump on that so much, at least in the early phase, to make sure things are perfusing well. But our overall goal is to maintain consistent blood pressures with guidelines normally, a little bit down the road. But we never want to use ACEs, ACE inhibitors, or ARBs, which are the angiotensin receptor blockers. Example would be like losartan, because these medications can affect your glomerular filtration rate of your kidney. And so there's enough things that could cause your serum creatinine to go up after a transplant that we don't want to complicate matters by adding other things in there that can do that too. So we generally avoid these things post-transplant, at least for the first 3 months or so. Hyperglycemia, or new onset diabetes after transplant, does happen to people. Risk factors are the same ones that they are for regular diabetes. Okay, family history, if mom or dad, brothers, sisters had diabetes, the risk will be higher. If they ever had borderline diabetes in the past, maybe a mom who had gestational diabetes, the risk will be higher. Age, just as we get older, our pancreases don't work as well, so anybody over the age of 45, for example, could be at increased risk. Ethnicity plays a part, so African Americans, Pacific Islanders, Native Americans, or Hispanics are going to be at increased risk for diabetes. And then obesity would be another factor. So some things we can control, some things we can't. Patients kind of freak out when they come into the hospital. They never had diabetes before, never had to get insulin, and now they get a diabetic tray, they're getting insulin, they're like, what happened? So this is kind of a drug-induced diabetes in the beginning, especially because of the steroids. So it's important to let the patients know that. Hopefully the sugars are going to correct with time as the steroid doses come down, but the risk is always going to be there because the steroids and the tacrolimus will increase your risk for diabetes down the road. Maybe about 20% nationwide develop new onset diabetes after transplant. Lipidemia is another issue with these medications, and so we need to control for that. And so one of the leading causes, just FYI, of death after transplant is cardiovascular disease. We have hypertension, we have dyslipidemia, we have diabetes there. So it's really important that they follow up in their post-op care to make sure we're taking care of those things. here's a little map I thought was helpful to kind of show you some of the overlap of these medications in terms of their toxicities. And so obviously the risk will be higher with some of these agents. You have the calcineurin inhibitors, the nephrotoxicity, peripheral neuropathy, diabetes between these two, the steroids and the calcineurin inhibitors. The steroids, have their issues that we'll talk about, and mycophenolate, which is MMF down here, has bone marrow suppression and GI upset, and we'll talk more about that as well. And all of them increase your risk for infection and malignancy because they reduce your immune system's ability to fight those things. All right, so some things to know about the kidney after transplant. Any kidney, whether you have a lung, liver transplant, whatever, you still have to worry about the kidneys and some drug interactions that can cause nephrotoxicity. So what happens here is you have a glomerulus, okay, right here, and you have the afferent flow into the kidney, and then you have, actually let's see here, and then we have the efferent flow. Here's the afferent arterial, and there's the efferent arterial. And so you have the blood flow coming in, it gets all filtered and comes out here. Well, tacrolimus, cyclosporin, they vasoconstrict this area right here, so it reduces how much flow gets into the kidney. NSAIDs do the same thing. So we don't like to use NSAIDs for pain control in our transplant patients because they add an additive effect and they cut the flow here, reducing the GFR. Vasodilation occurs down here with the ACEs, right? I just told you we avoid these after the transplant. And the ARBs we also work down here, and they cause vasodilation of this area. So with less coming in, more going out because of the vasodilation here, you reduce the pressure in the glomerulus, and that reduces the filtration pressure, reducing the GFR. And that can affect kidney function. So that's why we avoid those in the early phases after transplant. Chronic nephrotoxicity is another problem long term. We can't really do much about this. The data is kind of confusing, or at least mixed results in the literature, whether it's when we have patients that have failing kidneys in the long term, is it because of chronic rejection? Is it due to calcineurin inhibitor, long-term nephrotoxicity, combination of both? And so there's different data out there, and we're still trying to sort that out. And we haven't really gotten better yet at preventing that. Neurotoxicity, I'd mentioned that. This is more common with the tacrolimus. Tremors, the headache, the altered mental status, the cognitive defects, the delirium, coma have always been reported. And it's not always level dependent. And that gets a little tricky. If you raise the levels really high on anybody, they're going to have these kind of side effects. But some people can have these kind of side effects even at normal levels. So it kind of depends on the patient. Seizures can happen also. So we have to be cautious about patients that have a history of seizures, right, coming in for a transplant. We have to make sure they're not on medications that are going to interact with their calcineurin inhibitors, like Dilantin, Tegretol, which is carbamazepine. Those will interact with their immunosuppressants and cause the immunosuppression levels to drop too low, and that could then trigger rejection if we're not monitoring or paying attention to those. So we like to use medications that don't do that as much, like Keppra, for example, and some other medications out there. The lacosamide, lamotrigine are also do not use the CYP interaction system, or they're not metabolized through the CYP pathway in the liver. So then you can have anti-seizure meds on board without affecting your immunosuppression. Now, occasionally we see patients develop PRESS syndrome, which is posterior reversible encephalopathy syndrome. You're going to see this like in a patient who's just not like waking up after the transplant. They're just kind of like confused. They should be awake, have no explanation for it. So, team's going to like do your, be worried about something happening in the head. So they're going to get a scan, either a CT. If it's negative for like a bleed or some kind of major event there, then they might get an MRI. And then if there's PRESS syndrome, you're going to see a certain pathway, not a pathway, but a presentation on the MRI that's going to show you that the patient has PRESS. We see it occasionally. I see probably at least a case a year, given the number of transplants we have here. All we have to do is just switch the calcineurin inhibitor to a different one, and that usually fixes the problem. So when we think about nephrotoxicity with these medications and interactions, we have to think about inducers of the CYP3A4 system and inhibitors of that system, and we also have to think about other medications that could cause additive nephrotoxicity. Things I haven't mentioned yet, like aminoglycosides, amphotericin, contrast. Those all things have to be weighed carefully before we give them to our patients to make sure we're not going to cause some kidney dysfunction. And here's just an example of some other medications that can affect our calcineurin inhibitors. diltiazem and verapamil. So let's say we have a patient with atrial fibrillation post-transplant, which can happen occasionally. Maybe a beta blocker might be a better drug for rate control, at least in terms of drug interactions. If we're going to do it for the very short term or something, it's probably we can adjust the levels accordingly. But if it's a long-term thing, maybe we can do beta blocker instead. Other things like grapefruit juice, we counsel all our patients to stay away from that. Protease inhibitors, and that includes the HIV protease inhibitors, or the new hepatitis C protease inhibitors. Those will all drive your calcineurin levels up. And all of our azole antifungals. That means like your voriconazole, your fluconazole, those will all drive up levels. So we have to monitor them closely when we're adding them on or taking those off a profile. And then off to the right, we have medications like the anti-seizure medicines that I talked about, rifampin, which we use for TB, and St. John's wort, which is used over-the-counter herbal product, that can also affect levels. So when we counsel our patients, when they leave the hospital, any medication that they want to take, they should check with the team first, if they're going to buy it over the counter, because even all herbal, all natural products, they can have interactions and affect drug levels. All right, so we have the corticosteroids. They basically, work a few different ways. It's an important part of our immunosuppression, but they come with a bunch of side effects you guys see on a daily basis when you're working with these guys, right? They have high blood sugars, they have mood changes. Oh my goodness, they could be all over the place, up and down, sad, angry, throwing fists on the phone, calling 911 because they think they're in jail or something. It's really, it can be kind of wild. So, but they get through it, and then, a couple days and they come out of it. But boy, those steroids are potent stuff. Let's see, mycophenolate, the anti-proliferative we use, it inhibits the T and B cell proliferation. It comes in two forms, right? We use the CellCept, which is the one you guys mostly see. It's given twice a day. It's usually 750 milligrams twice a day for a kidney, 1,000 milligrams twice a day for a liver. But this one can cause some stomach upset, nausea, vomiting, some abdominal cramping, some diarrhea. And so when we think that the medication's causing that, we'll switch them to the Myfortic. And this one's enteric coated. It gets absorbed lower in the GI tract. There's supposed to be less side effects. So we'll switch them over to that. But the important things to know about this one is that it's not available as a solution, so the patient will have to be able to swallow this whole, because otherwise we're defeating the purpose of the medication at the beginning, because it's enteric coated, helps it get absorbed lower. So if we're breaking it up, then they're not getting the benefit and they're still going to have those side effects. And the dose conversion is not the same. So if you were on a certain dose of mycophenolate and now it's different with the Myfortic, that's okay. There's a little bit of dose conversion that's involved there. Now, another important thing to note is when I'm reviewing profiles, I'm making sure that we're giving the mycophenolate on an empty stomach. And that's because our patients should be able to kind of have what they want with their meal times, for the most part. And so they like their dairy products. Some of them are really excited, kidney transplant patients, of having dairy products because they've been told to stay away for it forever because of their phosphorus before the transplant. And so now they can maybe have some dairy, some milk with their cereal, yogurt in the morning or something. So I don't want the medications to prevent that from happening. So let's give the mycophenolate on an empty stomach before breakfast with the tacrolimus, and then at 9 p.m. at bedtime. Think of this drug like a quinolone, like Cipro. You have to avoid those same interactions that you do there. The calcium supplements, the antacids, the Maloxes, all those things, iron and stuff, because it'll bind to this drug and prevent it from getting absorbed. Sirolimus is another medication we use, more long-term transplant, and we usually bring it in when when we're individualizing therapy for a patient based on how the patient's doing, some adverse effects the patients may be having, etc. This medication works differently than the other ones we talked about. It originated, was found on Easter Island, Rapa Nui, so that's where the name Rapamune comes from that Rapa Nui, from the Easter Island, those big old statues you guys are familiar with. And it's available, as a suspension or tablet. It's given once a day because it has a really long half-life. And when we have patients on this, we don't need to check levels, say, every day because it has such a long half-life. Maybe a couple times a week is sufficient for most patients. Now, some side effects with this one is that it can cause, some things we should always know about is it can cause some kidney dysfunction in the form of proteinuria, right? And when it's combined with cyclosporin, we've seen increased nephrotoxicity also. So we just have to be monitoring for that. It's really bad increasing your cholesterol and triglycerides, so we got to monitor those closely. Some things you see here in the hospital more commonly would be things like a pneumonitis. So anybody who comes in from the outpatient and they're on sirolimus, they come in with some kind of pulmonary thing, we have to go through all of our regular things we're concerned about. But in addition, we always have to worry about pneumocystis pneumonia, right, because they're on immunosuppression. So it has to be on our differential. And we should also be thinking about pneumonitis caused by this drug. And there's no way of really diagnosing it based on this, as a drug causing it. You're basically excluding anything else. And if you're just left with sirolimus and no other explanation, then the team's going to stop this, and the patient should improve within a couple weeks or so. Remember, it has a really long half-life, so it's going to take a while for this to wash out of the system. Patients can also get mouth ulcers, canker sore-like things in the mouth, so we have to and that doesn't tend to be dose related. It can be, but it occurs at lower levels too. So we usually use topical steroids to help with that, and we'll have to do something with the sirolimus if it's too problematic. Here's a little chest x-ray of the interstitial pneumonitis for a little more information. Affects both lungs. It doesn't appear dose dependent, and it takes a while for it to improve after you stop it. Any questions so far? I know I'm kind of going fast, but I have a lot of material, so is the pace okay? Good? All right. Let's talk about kidney transplantation. I talked earlier about every patient comes in a different situation, makes them unique. And so this also has to do with the kidney and how it got here. And it relates to the donor factors, So how old was the donor? Did the patient have hypotension at some point in their ICU course? Were they on pressors? Did they have a super high sodium level? Did they have some kind of infection in the ICU or before they harvested the organs? Other comorbidities, like did they have diabetes, hypertension? And was it a deceased donor or a living donor? Those are all going to affect how well the kidney works right away when they put it in. There's other things too, like the organ, like how far did it come from? How long was it sitting in preservation solution before they put it in? Was it pumped or not while it was waiting, to get put back into the organ? Was the liver, like a fatty liver? And what was the serum creatinine of that kidney at the time they harvested it? Was it higher or lower? That's all going to play a part. And then, of course, you have recipient factors, too. How sick was that patient, before they got their liver transplant? We know that based on their MELD score. What's their immune competence level? Are they over immunosuppressed already? Patients who are really sick or cirrhosis, they're going to already come in immunosuppressed. Or if they're a previous transplant, they're going to come on immunosuppression. So these are all going to be factors that play into how well a kidney will do or a liver will do after a transplant. So to help make sure things are going a little bit better for these kidneys, we give our kidneys some induction therapy. And induction therapy, basically, we're using Thymoglobulin. We used to use some basiliximab. Maybe we're going to use it again. We'll have to talk to the transplant team about that. Other centers use this other drug called Campath. But the whole purpose is you're basically providing that punch at the party we talked about to allow the kidney and the host to kind of get a little more acquainted in the beginning. And the whole purpose is to help prevent rejection. And this medication works for about 3 months after transplant, knocks out all your T cells, and we'll talk a little bit about that. But the whole purpose is to facilitate some good interactions between the host and the organ. So some other things that we look at for kidney transplant patients, we have donor-specific antibodies. So we'll measure the blood of the recipient. We'll look and see if they're making antibodies to the donor. If the HLA matches are really high, that could increase the risk of rejection. And if a patient's sensitized, like they're just going to be increased, their immune systems are going to be a little more aware, okay, or sophisticated or whatever, because they've seen more things. So that means like they have previous transplant, they've been exposed to that organ. If they've received multiple blood products, their immune systems are going to be more sensitive. Women who've had a lot of pregnancies, their immune systems are going to be a little more sensitive. Or people with high panel reactive antibodies, they test positive against more donors in that region. Those are all going to set the patient up for more rejection down the road. So we're probably going to have to use more immunosuppression in those types of patients. Induction therapy, so the benefit is you're helping prevent rejection, which is a good thing, especially for a kidney, because a kidney that rejects, like if you take 2 kidneys from the same donor and give them to 2 different people, one rejects and one doesn't, and you measure them a year later, that kidney that rejected, even if you reverse that rejection, that kidney's still not going to be working as well as the one that didn't reject. So it's really important to prevent rejection. So that's all the benefits of the induction therapy. The downside is that it does increase your risk for maybe malignancies and some and so those are some of the things that you have to expect, and risk-benefit analysis all the time. It also causes people to have like flu-like symptoms, right? So when they're getting those infusions, they kind of feel like the flu, things of that sort. We help prevent that with the Benadryl and Tylenol, things of that sort, but that's still something patients report. Okay, let's see. So let's talk about some thymoglobulin. This is something you guys see a lot of. And what this does is, remember, it helps provide the punch at the party. We use it for the induction therapy, and it knocks out a lot of the T cells. The T cells are responsible for the majority of the acute cellular rejections we have after a kidney transplant. We're giving this now to both recipients of deceased donors and living donor kidney transplants. The difference is, for the deceased donors, we're going like 5 days, or a total of 5 mg per kilo course, whereas with the livings, we're doing a 3-day course. And the reason for that is that we had a little bit higher incidence of rejection with our living recipients of living donors, and so we wanted to give ourselves a little bit of a buffer by using a 3-day course. It's not unusual. A lot of centers are using induction therapy for both living and deceased donors. But we have to worry about some side effects with this one. So we're checking the white count every day. We're checking the platelets. We're making sure the patient's tolerating it okay. And so what we do is that I've set the order sets up that we're always pretty much ordering the thymoglobulin after rounds. Gives the time for the team to assess how the patient's doing. And so they're usually given around, pre-meds at 2:30 and the thymo generally at 3 now. And I like to be conservative with the infusion rates in the beginning, because remember that cytokine release syndrome that happens? That can cause people's blood pressure to drop, be hypotensive, be tachycardic. That's obviously not a good thing for anybody with a heart condition or just in general, because maybe we need to give them more fluids now for the hypotension, and the kidney's not working, so now they're getting volume overloaded, then we have to deal with those issues. So I think we can just avoid a lot of that if we just give it a little slower in the beginning. So I advocate for 10 hours for the first dose at least, and then after that we can go 8 hours on the second dose, and then 6 hours for the dose on the remaining patients. Now, some patients are hypotensive after transplant. We have a patient in the house now who just blood pressure runs low, like systolic in the hundreds, like 100 or 90s. Just that's how they were. They came in on midodrine. And so somebody like that, I'm not going to push the thymo infusion rates on. I'm going to be very slow with that so we don't make that worse. So we give the pre-medications, we give the Benadryl and the Tylenol beforehand, and we're using our daily steroid as our pre-med, so we're not having to give our patients too much steroids. So that's why you guys see the methylprednisolone set up in the afternoon. Sometimes that causes the sugars in the afternoon to be really high, so then the endocrine team will come along, they know what time of day they're getting the thymo and the steroids, so then they'll maybe give an NPH dose, sometimes of insulin in the evening to help offset that. Now, if a patient does have hypersensitive reactions, what are you supposed to do? Well, I think you guys have all been there, but you're going to hold the infusion, right? You're going to manage the system, stabilize the patient. The patient needs the thymo. It's not like an anaphylaxis reaction usually, right? You're obviously not going to restart if that happens. But most of the time, if it's just hypotension, tachycardia, stop it, manage the symptoms, and then when the patient's stable, restart the infusion at half the rate. Oh, and then another thing too, it's not cleared by dialysis. So some of you do I need to wait for dialysis before I give my thymo and stuff like that? It's not cleared through dialysis, so don't worry about that part. Just think about the blood pressure. Sometimes blood pressures drop on dialysis. This medication can drop it also, so maybe we'll just do a longer infusion. And if you're concerned about that, or if you see the blood pressure low, then maybe call your pharmacist and we can change it, so give it a longer time. So when a patient needs dialysis, things we're trying to avoid if we can, whenever possible, is things that can cause that. So we have these AEIOUs, right? You guys are familiar with their valves. So A for acidosis. We do dialysis for electrolyte disorders, usually high potassium levels. Ingestion or intoxication, maybe if some medication is cleared by dialysis, we have to get the levels down quickly. Volume overload and uremia are some things that we dialyze for. So delayed graft function, the definition in the literature is we need dialysis within a week after transplant. It's not something ideal that you want to do, and if you think about it, it doesn't really tell you how the kidneys doing, because sometimes if the patient's volume overloaded, we have to dialyze them, or if their potassium's high, we have to dialyze them. It doesn't really tell you how well the kidney's working. But we want to prevent this whenever possible, because UNOS keeps track of this, and so reason why we don't flood our patients with fluids, and you have that urine replacement protocol, things of that sort. We try to minimize as much as possible. Renal diet, so they're not getting as much potassium, things of that sort. Causes of elevated serum creatinine after transplant are all over the board. You have pre-renal causes like dehydration, bleeding, thrombus, sepsis, certain medications that we talked about. You can have interstitial nephritis, you have rejection, you can have a UTI, and then you can have some obstructions, post-transplant prostatitis, maybe a neurogenic bladder. All these things the team is thinking about when we have an elevated serum creatinine. We have to do ultrasounds, we have to do biopsies to try to figure out what's happening and then manage it accordingly. Now, we talked about the calcineurin inhibitors causing nephrotoxicity, and so some programs will back off on the calcineurin inhibitors, we'll use less of them, we'll add some Sirolimus, and so here's some data, just some of the studies out there talking about that, but I'm not going to get into that right now because we have a lot to go over. Any questions about induction therapy? Okay, let's talk about rejection. And there's two types. There's acute cellular rejection, which is the T-cell mediated type, and then there's the antibody mediated type of rejection, which is B-cell mediated. And we never really know which one we have until we do a biopsy. And again, I'm pretty much talking about kidneys, but this also applies to livers. So hyperacute, we don't really see that anymore because we've gotten really good about making sure the donor and the recipient match up. We as a transplant program around the world. Acute cellular rejection tends to be the most common type. It occurs in 80% or more of the transplants. The B-cell mediated rejection is less common. And then you have the chronic that we talked about. Acute rejection now falls into the two types I talked about, and we do a biopsy, and there's criteria. In Banff, Canada, a few years ago, they sat down, the nephrologist, the kidney transplant world, they sat down to agree on what do you see on a biopsy? This will mean this type of rejection. And they categorize it, and there's different stages of rejection. So if it's a T-cell rejection and it's mild, they'll use steroids because they found the data shows that the steroids will be enough to help reverse that rejection. But if it's a grade 1B or higher rejection, those tend to be resistant to steroids. So then we might need something like Thymoglobulin to treat that type of T-cell rejection. And we dose it the same way we did for the induction therapy. 1 mg per kilo a day for 5 days tends to be the standard. Now in terms of if it's a B-cell type of rejection, then they're going to stain for it, and it's going to be a C4D positive stain. And so that means it's a little complement protein that's on the basal membrane of the kidney. They'll stain for that, see it there, then they'll know there's some kind of B-cell process happening. So then, if it's that type of process, then we need to use different medications. Thymo is not going to work for that because, remember, Thymo works on T cells. We have to pull out some other things you guys may be seeing for that, and we'll talk about that in a second. So, clinically, when you suspect rejection with a kidney, you're going to see increased serum creatinine. The urine output's going to drop. The blood pressure may go up if they're retaining that fluid, and they could have some edema. For liver, you're going to see an increase in your hepatic enzymes, your AST, ALT, your bilirubin, maybe your alk phos will go up. And you also could see some changes in your color of the bile. I think Dr. McKill will talk a little bit about that later. So rituximab, what is that? How many of you have administered rituximab for our patients? You see it occasionally, right? Less common though, and this is to help target B-cell type of rejection, or the antibody-mediated type of rejection. This is an anti-CD20 monoclonal antibody. We only usually give it as one dose, 375 milligrams per meter squared, and we also pre-medicate with this one like we did with the Thymo. We give the Tylenol and the Benadryl, and we give some steroids beforehand. For this infusion, we're going to start at 50 milligrams per hour, and we're going to titrate up every 30 minutes as tolerated to a maximum rate of 300 milligrams per hour. And it infuses over a short period of time because the bag's not that big. But you're going to monitor the vital signs every 15 minutes and document it in a computer. And according to hospital guidelines, this one here, we can administer this on the floor or any level of care in the hospital. Adverse effects are rare, but we're looking for things like hypertension, the fever, the chills, same things we talked about with the Thymo. And then rarely you see angioedema, bronchospasms, things of that sort. Now IVIG, you guys are probably more familiar with this one. We can also use this medication for B-cell mediated rejection also. And so what it does is basically is a mop, and it takes out all of the antibodies, or a lot of the antibodies in the recipient's bloodstream. That's good and bad antibodies. So it is a form of immunosuppressant in itself. But the dose varies depending on the severity and what our treatment plan is going to be. It's anywhere between 200 milligrams per kilo to a gram per kilo a day. And what I want you guys to know about this one too is that this one requires a dedicated line, and we need to titrate the infusions with this one upwards. So we start at a very low rate, 1 mg per kilo a minute for 30 minutes, and then we increase, slowly. Basically, like if you start off at 50 mils per hour for the first half hour, then you go up another 50 mils per hour for the second half hour, and you increase by 50 mils per every half hour as tolerated to the maximum rate that'll say on the label. It's not removed by a dialysis either, so it's okay to infuse that with this one. But if a patient has B-cell rejection, they could also be getting plasmapheresis, correct? Because the pheresis is also removing the antibodies, the good and the bad in the body. So since it's removing antibodies and in larger molecules, we can also remove the IVIG with the plasmapheresis. So we have to be worried about that. So always give the IVIG after a plasmapheresis session, not before, because otherwise we're just removing the drug we just gave, and this stuff's like really expensive. Adverse effects, just like any of the other immunoglobulin products, hypersensitive reactions, the flushing, the chills, the headache are common, so we'll pre-medicate with this one as well, Tylenol and Benadryl. But I think it's pretty well tolerated if we follow that titration schedule we talked about before. Infections. Basically, after transplant, people are at risk for infections just like you and I would be. But they also have some other things that they could be susceptible to that we're not. And those would be opportunistic infections, certain viruses, certain fungus that could come along. So here's a list of all the things, but this, a lot of people could be concerned about these. But the CMV, this one here, the cytomegalovirus, that is an opportunistic infection. People on immunosuppression, HIV patients, these are take advantage of the situation and cause problems. You have BK virus for the kidneys. That's an opportunistic infection that we have to monitor for. And we have pneumocystis pneumonia, which is a fungus pneumonia, which is the pneumocystis jirovecii. That's something that we give Scepter for to help prevent. Here's just a little timeline schedule of when we might expect certain things to happen post-transplant. So we think about this when we're administering our medications. For example, we have a patient in the ICU right now, has very low white counts, and so we don't want to give them Sceptra or Valsite right now because those medications can cause leukopenia. So since we know the time frame of when a pneumocystis pneumonia is going to occur, say more than a month out after transplant, we're not so concerned about having the patient on Sceptra at this time point. This is like, they're post-op day 3 or something today. So the team can, we know that we're safe avoiding that for right now. Eventually, we're going to have to put the patient on something. We'll have to wait and see what the white count does. The Valsite, that can cause leukopenia. And so we might get a CMV infection in a patient who's at increased risk. So what we can do is we can monitor CMV PCRs every week to make sure the virus isn't showing up in their blood while the patient's off the medication to make sure it's not becoming a problem. So we have ways, like we can use this information to help us know what to use for our patients and to take care of them. Patients, basically what we define with fever and transplant is lower than you might usually be used to for our patients. Anything above basically 38 degrees in a transplant patient is considered a fever, which translates to I think 100.3, 100.5, something like that. Because remember, they're on immunosuppression. So 100.5 for a transplant patient might be 102 for somebody else. So we're obviously going to do a workup anytime the patient has a fever. We're going to do pan cultures, maybe get a chest x-ray, put all the clinical pieces together to see what's going on. Wound infections, you guys are always on top of those, managing those and examining them, documenting them, and controlling blood sugars, all of that really helps. We do scan for urinary tract infections, you guys are familiar with those processes. And here's some medications that we commonly use after transplant. We talked about cytomegalovirus. Most people are going to be at increased risk because most of Americans have been exposed to this virus, maybe more than 80% of them. And so if they've been exposed or the donor was exposed and the recipient hasn't been exposed, that puts them at moderate to high risk. And so we need to prophylaxis them for the right period of time, somewhere between 3 to 6 months, depending on the risk. Patients that are low risk, so the donor was CMV negative and the recipient is CMV IgG negative, then we can use acyclovir for 3 months. And the reason we give them anything is because of herpes virus, and so that can cause some potential problems after a transplant. So the acyclovir will help protect against that. All of our patients, if they don't have a sulfa allergy, will get Septra for prophylaxis for at least 3 months after transplant. This is a little bit different depending on the organ type, but both regimens have been shown to be effective in preventing that from happening. Some of our liver patients are increased risk for Candida or Aspergillus, so we have some guidelines in place to decide if we need to put them on fluconazole or mycophenolate, depending on the severity. So if we have a new liver transplant who comes to the ICU, if they're on dialysis, they're going to need antifungal coverage, usually in the form of mycophenolate. If the patient had to go back to surgery shortly after the transplant, maybe they was worried about a bleed or looking at something, then they're going to need to have an antifungal. If the case was really complicated, got a lot of blood products, say more than 20 units of blood, PRBCs in the OR, that would be a risk factor for fungal infection, meaning it was more complicated, maybe potential source of infection, so we put fluconazole in those situations. So we're always looking at that. And so we usually stop those by the time, at least the mycophenolate, we stop those by the time they leave the hospital. If they're on fluconazole, I kind of keep them on it when they leave. I mean, typically we could stop it, but remember fluconazole is an azole, and that interacts with our calcineurin inhibitors, right? So if I stop it at the time of discharge, then they show up in clinic, who knows what their level is going to be. So I actually kind of let the clinics manage that now, so they know when they're stopping it, and they have the follow-up to make sure that they're monitoring the levels and things go a little smoothly for those patients. Any questions about the kidney transplants? Okay, let's talk about livers. So let's say you have a new liver patient who comes to you, if you work in the ICU, for example, and some things that would be evidence that the liver is not working as well as we might hope. Or this might translate into helping you understand why the team is doing what they're doing. So mental status is an important thing after transplant, because if the liver's working, it's going to metabolize the pain medications that they got in the OR, the anesthesia, all that stuff. And so if the patient wakes up, that's a good sign that the liver's working. Also, we're going to be looking for evidence of acidosis, because the liver metabolizes acids. So for example, like lactate, for example, right? If the liver's working, it's going to metabolize all that. We're going to monitor lactate levels, watch them go down. So that would be a favorable sign if there is no acidosis. We're also going to look at INR, right? You've heard LFTs, like liver function tests or whatever, like AST, ALT. Those are not liver function tests. That tells you have no idea how the liver's working. You need something more sensitive, like an INR, which is a clotting factor, right? That's going to be sensitive to how the liver is working. So we want to see a favorable drop quickly in the INR without the need for FFP. That would be a favorable sign that the liver is working. You're also going to be monitoring your drains, making sure the bile color is appropriate, etc. Potential complications you guys are familiar with. There's nothing really new on that slide here. But sometimes we may be concerned, like if the liver function tests, liver's not recovering as fast as we might like, or the AST, ALT are not coming down as fast as we might like. Could be because there's some renal perfusion or root perfusion injury with the liver. So sometimes we'll add a mucomist drip just to kind of help. It's an antioxidant, free radical scavenger. Data is kind of mixed on how effective it is, but it doesn't really hurt the patient any. So sometimes we'll add this to help the liver recover after a transplant. Patients are going to monitor the coagulation, may do TEGs. We don't usually use DVT prophylaxis in this population after liver transplant because they've been so coagulopathic before. This population hasn't been shown to be a higher risk group for DVTs. So the surgeon, they had a large surgery, so the risk for bleeding potentially, I guess, is there. So the team generally doesn't use DVT prophylaxis for most of our liver transplant patients, but they should have the SCDs, should be ambulating as much as we can if that's possible for the patient. And then they're on the other stuff like you guys see all the time. Okay, Sirolimus. So this medication we talked about has its role in therapy. We use it in kidney transplant patients when we're trying to minimize nephrotoxicity with the calcineurin inhibitor, so we add a little Sirolimus so we can lower the calcineurin inhibitor dose. In the liver transplant population, we use this for the same reason. Like if we're having trouble with the kidneys and nephrotoxicity going on, we want less CNI, let's add a little bit of Sirolimus because it doesn't have as much kidney toxicity. But also, Sirolimus is helpful in patients that have develop malignancy after a transplant. This drug, the Sirolimus, what it does is it helps prevent cell turnover. It helps prevent cell growth. So cells that are prone to rapid development, like T cells in response to rejection, or cancer cells, right, they turn over high, Sirolimus is going to help slow those types of things down. So Sirolimus is a drug of choice in patients that develop malignancy after a transplant. In that situation, you'd stop your calcineurin inhibitor and now put the patient on Sirolimus. Okay? The other situation where we might use Sirolimus in a liver transplant patient is it helps reduce the fibrosis development. Patients that have Hep C, recurrent Hep C after a liver transplant patient, that Hep C comes back a lot faster than it initially did in their original liver. And so that can then destroy the new liver they just got. So one thing that we can do then to help slow the development of fibrosis down in that liver is to give them Sirolimus. For the same reason it works on anti-cancer cells, is it helps to slow turnover, thought to help reduce the formation of fibrosis afterwards. And so that's where you'll see that in some of our patients sometimes. Liver biopsy, here's just some information about when the team might switch to a transjugular biopsy versus percutaneous. That might determine who's going to do the biopsy or something like that. So now, when I came into this talk today, I was kind of given a tall order. Because obviously our patients, transplant patients, a lot of them in the hospital, they're complicated, there's a lot of stuff going on. At the same time, we have this new kind of hepatology service, and you guys are seeing a lot of new things with them and wanting to know how to take care of those patients to preserve life before that. So I want to kind of now talk a little bit about end-stage liver disease, hitting some highlights that I think may be helpful to you, because just having talked to you guys on the floor, some of you approach me, could you give me an in-service or our unit or in-service on this kind of topic or whatever. So I want to take this opportunity to try to hit some of those things and address those questions that you may have. So cirrhosis, it's basically a result of chronic liver disease. The liver becomes diseased, and it's more common in hepatitis C or alcoholism, NASH, which is non-alcoholic steatohepatitis. So that's basically fatty liver in someone who doesn't drink alcohol. You see it in Hep B also. So common complications we have with cirrhosis are ascites, the GI bleeding, hepatorenal syndrome. Patients have hepatic encephalopathy and they're prone to infections like SBP. So let's talk about hepatic encephalopathy real quick. Basically what it is it's a potentially reversible situation. If we can jump on it early, and we know what some of the triggers are, the causes, having understanding that better, we then have ways now of trying to reverse that. And the etiology is multifactorial, but in general, for the most part, we chalk it up to ammonia is causing the problem. It accumulates in the body, and that can be toxic on the brain. But there's potential triggers in this population that can increase somebody's risk of developing encephalopathy. So if the patient becomes dehydrated, right, they're taking a lot of lactulose at home, okay, and now they're having a lot of diarrhea, that can tend to dehydrate them and set them up for hepatic encephalopathy. If the patient has ascites, they're usually on diuretics, right? If the patient's diuresing too much, they can get dehydrated and trigger hepatic encephalopathy. If the patient's not eating enough protein or they're eating too much, that could be a problem. So our goal for these patients is somewhere between 1.2 to 1.5 grams per kilo a day. If patients are constipated, right, they're not clearing that ammonia out of the gut, and the ammonia then gets into the bloodstream, that's going to increase the risk for hepatic encephalopathy. So we want to avoid constipation whenever possible. Medications can contribute to it too, right? Opioids, we know that can just make anybody goofy. Well, for a liver patient, they're more sensitive perhaps. That could worsen the encephalopathy, can cause constipation. That increases the risk. Benzodiazepines, Zolpidem, Benadryl, all those things should be used with caution or totally avoided in our population whenever possible. Infections can trigger it too, SBP, UTIs, pneumonia, so we have to screen our patients for those. GI bleeding can do it, just the progression of the worsening liver disease can cause it. Acute kidney failure can cause it. Maybe you have some now toxins that are accumulating, you're clearing less drugs, you have uremia, something like that can cause worsening of encephalopathy. A TIPS procedure, right? When they go in and they put a shunt in the patient because of some complication, the liver now is being bypassed, right? And so now the liver can't metabolize or get rid of that ammonia as well, because now it has a way of just bypassing the liver. That can perpetuate and cause hepatic encephalopathy. And the low sodium levels can do it in hypoxia too. So symptoms, you guys probably see this for your patients. They have personality or mood changes. They have poor concentration. They can't focus. They have reversible sleep-wake cycles. They're up during the night and sleeping during the day. They're kind of delirium. They have asterixis, where they do the flapping. And their speech could be slurred and slow movement, things of that sort. They have the West Haven criteria. So the members of our team are looking at this and they grade the encephalopathy, and this kind of just helps determine, whether our therapy is working or, how bad the patient might be getting. But one thing to kind of point out is we talked about ammonia as being a leading cause or factor in this. So this is kind of weird but it's true, is that we know that ammonia is playing a part, but if you check the ammonia levels for a patient, it doesn't correlate with their symptoms. Okay, we know that ammonia is a factor because we give them things to help manage the ammonia, and we know that they get better. But you can't look at a level and say it was higher, and then the level goes down and expect them to be better. You can have somebody with a higher level be more awake than they were when they were on a lower level. It's kind of weird that way. So we don't tend to check ammonia levels because we find them not very helpful. So one of the things we do is give you lactulose, and so that's kind of first line. It's been the most studied. It's been around a long time. And what it does is it helps the body prevent absorption of the ammonia. It takes the ammonia, it turns it into a cation, making it NH4+, and so that helps prevent it from getting absorbed. And then the cathartic effect of the lactulose helps you get rid of it from the body. So that's why we use it. We got to titrate it, especially in the beginning. Patients are really encephalopathic. We give them, a lot up front just to get the bowels working, but then the team backs off. And our goal then, once the patient's more awake, is merely just have maybe 2 to 3 bowel movements a day at the most. That should be enough. As long as they're having bowel movements, not constipated, that should be okay. Rifaximin is something else we use kind of as a second line agent. It's really good, but it's also really expensive, and a lot of insurance companies aren't paying for it. But it's an antibiotic, and it kills gut flora that are responsible for making the ammonia in the first place. It's given twice a day. It's generally well tolerated, not many side effects or drug interactions because it's not absorbed into the body. And there's some data out there showing that it helps reduce hospital admissions for patients that are taking it. Now, I know some of you have some questions about sodium benzoate because it's something relatively new that we've been using. And this is lower on the list of things that we're going to use because, one, it hasn't been studied a lot. Dr. Gish has had the more experience with it. He used to use it up in San Francisco for a lot of his patients, and so he has a lot of clinical experience to show patients have gotten better on it. What it is, it's a food preservative. They put it in a lot of things. It's included in Coke and stuff like that. It's just a food preservative. But we use it off-label to treat hepatic encephalopathy. And it's thought to help remove ammonia through the body by a different mechanism. This is like the urea cycle. And so a lot of the ammonia is eliminated through the urea cycle. But the benzoate, sodium benzoate, helps work up here, taking the ammonia and driving it out this way and making it excreted into the urine. So you're just allowing the body, giving it another way to help get rid of the ammonia. They use this for pediatric patients, this is a combination product. Kids that have inborn errors of metabolism and they accumulate these different toxins, they can help get rid of the ammonia by using this medication in combination with other things to get rid of it from the body. So that's how it works. So anybody who has kidney dysfunction that's not on dialysis but impaired kidney function, you're probably going to have an accumulation of the hippurate, which is also a uremic protein. So we should probably be avoiding it in those patients that are developing acute renal failure, not getting dialysis, because I'm not sure how effective it will be. It could make things worse. But if you're getting dialysis, it shows it is removed with dialysis, so then it should be okay. Okay, so one of the things that comes, one thing too is let's not give this with vitamin C. There's some data out there showing that it may not be safe to give it with vitamin C, so just don't give it with some juice or something like that, and that should be okay. Now, here's a flow chart. It's a really crazy diagram, but I know that I'm going to kind of explain this rather than show this to you really quick, but sodium benzoate, when it's ordered, I know can be kind of confusing for the nurses on the floor. So if a patient was on this before they came in the hospital, okay, we're going to treat it like a patient's own medication. They need to bring it in, and then it's going to be stored in the pharmacy. And then the pharmacy is going to dispense their product to you from the pharmacy downstairs. Okay, so if the patient was on this before, you have to talk to the family, have them bring in their sodium benzoate so we can use it. If it's a new start, it's probably going to come from our team, and then I'm going to order it and have it. It's made at an outside pharmacy and it's delivered to our inpatient pharmacy. And then they're going to unit dose it and send it to the floor. Okay, so usually we're going to use a suspension. So it's going to be in your med room, unit dose for the patient that day. When it's time for discharge, okay, the patient needs to take that home with them. So what the doctors need to do, or encouraging them, is that they're going to then, in their discharge orders in Epic, when they send it, they're going to send that sodium benzoate prescription to our discharge pharmacy. The discharge pharmacy sees that, they're going to take it over to the inpatient pharmacy and say, you know, this patient's going home, send their bottle upstairs to them, give it to the nurse so they can give it to the patient when they go home. Does that make sense? Okay, and that's just what that diagram shows right there. All right, let's talk about hepatorenal syndrome. Basically, it's it comes along with cirrhosis and ascites, and it's when the serum creatinine goes more than 1.5, and it's basically in the absence of any other that have caused that in our patient with cirrhosis. So there is no evidence of infection, there's no shock, there's no evidence of hypovolemia, patients dehydrated or anything of that sort. There's no nephrotoxic drugs that were given, et cetera, and there's no native or intrinsic kidney disease. Once you roll all of that out in the setting of cirrhosis and ascites, and you have an elevated serum creatinine, then we'll call it hepatorenal syndrome. And the good things is that we didn't understand this not too many years ago, but now we understand it's potentially reversible, and once it's recognized, we can find ways to try to reverse it and get the kidney function back. There's two types. There's type 1, which is a rapid progression of the kidney injury, and the serum creatinine is higher. It's more than 2.5, or the serum creatinine increases more than 100% compared to baseline in a less than a 2-week period. Type 2 is still hepatorenal syndrome, but it's the less severe type. It's just associated with serum creatinine greater than 1.5 and not meeting criteria for type 1. Triggers for hepatorenal syndrome are going to be bacterial infection, alcoholic hepatitis, large volume paracentesis, say more than 4 to 5 liters tap, aggressive diuretics, and GI bleeding. So what this is basically is you have patients with cirrhosis. They have the liver's releasing nitric oxide, so their SVR, systemic vascular resistance, is low, so the blood pressures tend to run low, and the liver, is like fibrotic, cirrhosis, and it's just like not sensing enough blood flow. So it's telling the kidney, hey, we're not getting enough flow over here. Start, getting me more perfusion. So the kidney starts reabsorbing more sodium, et cetera, right? It vasoconstricts the kidneys a little bit because you're trying to maintain good blood flow to the vital organs, the heart, the brain, et cetera. So it kind of sacrifices it to the kidney a little bit. So you have this SVR issue, the vasoconstriction to the kidneys, the activation of the SNS and the RAS system, which I just mentioned, and they could have impaired cardiac function. And so all of this helps this underfill theory, you're just not perfusing well enough to the kidneys. It's just taking its toll, and now the kidneys will start protesting, and the serum creatinine starts going up. So then we try to reverse this process, and we want to reverse it because the mortality is really high. You can see that people that develop type 1 hepatorenal syndrome, the mortality they're probably survival plummets. Within 30 days or 2 weeks, most of the people are dead. So we have to reverse this quickly, and important to recognize it. So people who are increased risk with this would be cirrhosis, ascites, people that have their kidneys are hanging on to every bit of sodium. It's recycling every bit of sodium in the body to try to maintain a volume, because remember, water follows sodium, so it hangs on to recycles every bit of sodium, and so with that water, so that they can maintain some kind of perfusion to the kidneys. That's why they're so edematous, and have the ascites and stuff. The body's using every bit of sodium. That's why we don't give them very much, because the more sodium you give them, the more water they're going to retain and make it worse, etc. So there's not going to be very much sodium in the urine. And then you have these other things that are happening as well. So what we're going to do is we're going to stop any agents that could be making it worse, right? So we're going to screen for sepsis, give them antibiotics if we need to. We're going to stop non-selective beta blockers that they might be on for their esophageal varices, because that's reducing blood pressure. That's not going to be helpful. We're going to stop diuretics. Then we're going to start MOA. What, you guys all heard the term MOA? You guys are all familiar with that? Which is an acronym for midodrine, octreotide, and albumin. And that's all going to help try to increase the perfusion. The midodrine is an alpha blocker. It's going to help increase your blood pressure, okay? And then the octreotide is going to help divert some of the blood in the gut back into the systemic circulation, and the albumin is a volume expander. So all of that is geared towards helping with reperfusion. And so here's some data out there showing you the benefit that the MOA therapy has on patients with HRS. Ascites, we just manage that, you know, because that's just problematic for people. It can become painful, things of that sort. So we're going to give them diuretics usually in the form of a loop diuretic and spironolactone, which is an aldosterone receptor antagonist, which increases potassium. But the loop causes lower potassium. So between the two, hopefully your potassium levels are going to be okay. But we should minimize potassium-containing foods if the potassiums are still running high, so we can maximize treatment. And we should also put them on a sodium-restricted diet, because remember, it's hanging on to every bit of sodium in the diet, which then translates to water reabsorption and edema, etc. All right, so I have some other information there in your packets, just some other things that I think you might find helpful in helping manage these patients. Before I leave, is there any last questions about anything that I've talked about so far? Okay, all right, thank you very much.